program promises enriching discussion and expert preservatives, shaping the future of medicine with each deliberation. Now, let us begin our first session with the free paper 3, a pivotal topic exploring the intricacies of hand surgery. This session sets the tone for a comprehensive exploration. Now, we invite our respected chairperson, Dr. Saumande Das and Dr. Khalid Alwadi and Dr. Shubhasini Rajandhiran to gracefully take the stage and take over the proceedings.
Thank you.
Good morning. So good morning, everybody, and thank you for being on time for our first session of the day. We'll start with our first presenter, Dr. Abhishek Sugumar. He will be presenting about lunate dislocation and its variation.
Good morning, everybody. Dr. Abhishek from Apollo Hospitals, Bangalore. I'll be presenting on lunate dislocations, a case series. Lunate dislocations or perilunate dislocations can be of multiple types, the great arc, lesser arc, the intralunate, inferior arc injuries. We're speaking about the Mayfield stage 4. The path of trauma can travel either ligamentous, causing perilunate dislocations, or perilunate fracture dislocations when the path of trauma passes through the bones. It can be transcaphoid, transcapitate, transequitral, and the path of trauma can also pass through the ulnar styloid. The displacement of the capitate further divides it into dorsal and volar types. Presenting the first case, it's a 32-year-old male who presented following a motor vehicle accident, injury to the right wrist, presented to us 8 days for post-injury. This is the preoperative X-ray showing a transstyloid, transcaphoid perilunate dislocation. The lateral view showing the proximal pole of the scaphoid and the lunate displaced volarly. This is the CT, providing more information about the injury pattern. The plan was an extended carpal tunnel approach, release of the carpal tunnel, neuralysis of the median nerve, the long flexors of the fingers retracted medially, FPL retracted radially, and the scapholunate block reduced back through the space of Poirier, which is the space between the radioscaphocapitate and long and short radiolunate ligaments. This is an extremely rare injury, the Herzenberg stage 2 lunate dislocation. This is a diagram representing the mechanism of injury with the midcarpal joint hyperdorsiflexed and pushing the lunate out of the lunate fossa. So the plan following the median nerve neuralysis was to assess the chondral status, followed by a reduction and fixation. This was the procedure. It was an ORIF with a Herbert screw for the scaphoid. The distal pole of the scaphoid was comminuted and required iliac crest bone grafting, which was followed by a lunar-triquetral and triquetrohamate pinning. 6 weeks follow-up, showing the results. Case 2, 25-year-old male, road traffic accident, attempted failed reduction at close reduction and pinning outside and referred to us 12 days from date of injury. This is the pre-op X-ray showing a transstyloid, transcaphoid perilunate dislocation with the path of trauma exiting from the ulnar styloid. This is the preoperative CT scan showing the sublux of the lunate and the distal pole of the scaphoid. Similar approach. So this is ORIF with Herbert screw for the scaphoid and something we call the reverse Lynch-Shield maneuver, the capitolunate pinning that helped us get the scaphoid back in length, followed by a dorsal capsular repair and a dorsal approach screw fixation for the scaphoid. The dorsal capsule was repaired with a suture anchor as seen on the AP film. Third case, 39-year-old male, road traffic accident, trauma to the left wrist. Slightly different injury pattern, a radial transstyloid, transcaphoid dislocation with the capitate sublux dorsally, lunate remaining in the lunate fossa. This is the intraoperative images showing the lunate articular surface facing us. A similar reverse Lynch-Shield maneuver and a volar approach for fixation of the scaphoid, and a lunotriquetral pin helps stabilize the fracture. The Lynch-Shield classification, this comes under the carpal instability complex palmar perilunate dislocations. The important prognostic indicators for such injuries is mostly the time to surgical treatment. Acute and delayed treatments generally have a better outcome, with acute presentations marginally providing better results, and the worst results in the chronic presentations. Open versus closed, no clear consensus on which is better. We prefer the open reductions, as we treat it as an intra-articular fracture to get an anatomical reduction and repair. There are studies showing an arthroscopic assisted closed reduction gives a better flexion extension arc and dash score. Time to injury being the most important. The greater arc injuries, as the scapholunate and lunotriquetral ligaments are intact, also seem to provide better results as compared to the lesser arc injuries. Salvage must be considered and explained to the patient preoperatively, and does not provide as bad results as we expect, low prevalence being the limitation. This is the Lynch-Shield maneuver, which helps get the scaphoid back in length. What we would like to describe is a reverse Lynch-Shield maneuver. That's with the wrist palmar flex, we pass a capitolunate wire that helps stabilize the proximal and distal row, that helps get the scaphoid back in length to get a good trajectory for the scaphoid Herbert screw. Because it's quite an unstable injury pattern and it's difficult to maintain the reduction before fixation. This is our team from Sahyadri at Pune. Thank you.
Thank you very much, Dr. Abhishek. Any question for Dr. Abhishek? So it seems pretty clear. I have one question only. I saw from your picture that you are doing volar open approach. Do you do dorsal opening anything for putting the screw or assessing the?
Dorsal opening whenever there's a dorsal instability. Like in the second case, we had to open dorsally and repair the dorsal capsule because there was dorsal instability after we reduced the lunate.
Okay, thank you.
Dr. Abhishek, thank you for your presentation. Do you think maybe a proximal row capectomy acutely might be an option for these patients?
Yes, as I said,
tried?
It must be explained to the patient, and if there is very comminuted lunate and there is chondral injury to the lunate, with the capitate articular surface and the lunate fossa intact, it provides almost similar results as an open reduction.
Have you tried it for these cases?
No experience for that.
Thank you. Thank you.
I request Dr. Krishna Priya Das to come on stage. He will be talking on conservative versus percutaneous screw fixation for fracture waist of scaphoid.
Good morning, everybody. My topic is conservative versus percutaneous screw fixation for fracture waist of the scaphoid, a randomized controlled trial. I am from Bangladesh. I am working in Bangabandhu Sheikh Mujib Medical University, Dhaka. 70% of our carpal bone fracture is still difficult to manage properly. 80% of the surface is covered with articular cartilage. About 5 to 12% of scaphoid fracture associated with other fracture. 70 to 80% occurs in the waist, and 10 to 20% occurs in the proximal pole. Blood supply of the scaphoid is very important. There is two predominant pedicular vascular, but dorsal supply is more important. Our hypothesis is percutaneous screw fixation is better than the conservative treatment for the management of the fracture waist of the scaphoid. The objective is to compare the outcome between the percutaneous fixation and conservative treatment for waist of the scaphoid fracture. Specifically, we objective to compare the pain status, to compare the range of motion, to compare the radiological union, to evaluate the incidence of complication, and to compare the patient satisfaction. In conservative group, below elbow forearm cast is applied, thumb is maintained in functional position, 80 to 80% of the union in 10 to 12 weeks. During this fracture, time is assessed radiologically for healing. If collapse or angulation developed after 3 months, then we do surgery. Percutaneous fixation in the volar approach. At first I mark, then introduce the K-wire, and then insert the screw. And immobilized in this case only 4 weeks. Follow up at 3 months. the solid union as well as the better range of movement and achieve the grip strength more than 35 kg. If the fracture in the proximal, near to the proximal pole, then we go for the dorsal approach. It is the same technique. Just make an incision near to the proximal pole, introduce the K wire, then fixed with the screw. Even in the bilaterally fractured scaphoid, in the right side there is no displacement, but in the left side there is the displaced fracture. We go for the screw fixation for the left side and conservative treatment for the right side. It is the doctor. But after 12 weeks, the left side, the range of movement, and as well as the union, radiological union is better in the left side. In two groups, there is no epidemiological difference between the group, but in the results, the union rate, union time, complication, considering complication, Maurice score and VAS score is better in the percutaneous fixation group, and it is also statistically significant. This is the final outcome. We achieved 96% satisfactory result in percutaneous group, screw fixation group, but 80% in the conservative group. Cast treatment for worst of the scaphoid fracture takes longer immobilization time, more chances of joint stiffness, reduced grip strength, longer time to return to work, whereas in the percutaneous fixation with Herbert screw results in predictable satisfactory union rate, good functional outcome with cost effective also. Thanks for patience hearing.
Any questions?
Nice presentation. The question is, so do you recommend fixing every scaphoid fracture if you see the fracture line on the X-ray? Is that your conclusion and recommendation from your study?
No, actually I do the CT scan. If there is a undisplaced fracture in the X-ray, we go in the plaster immobilization. But if there is a displaced fracture, we go for the CT scan and then fixed. Actually, it is a randomized control trial. So we do the CT scan, and if there is any displacement, we go for the screw fixation. But only in the bilateral cases, there is undisplaced. One is immobilized with the plaster cast immobilization, and in the displaced, one is fixed with the screw.
We have another question. Please come to the mic and hear your question. Thanks.
When you say displaced, what degree of displacement do you accept as not enough displacement to treat conservatively? Any displacement or less than 2 millimeters?
Not more than 2 millimeters.
Okay, thank you.
Thank you.
Thank you, very nice. So the next free paper, I'd like to invite Dr. Umar Farooq Baba, who will be talking about distraction histogenesis of the digits.
Hello, a warm good morning to all. I'll be talking about the distraction histogenesis of the digits. As we all know, hand is the most constantly exposed part of body to our own self. So we are the best judges of the aesthetics and self-image of our hands. And as such, fingers are the most exposed appendage and most susceptible to injury. And the hand function is particularly compromised when there is a loss of length, especially in case of short thumb and index finger. So lengthening of digits has become a challenge to plastic surgeons, and over the years, treating surgeons have developed different techniques to achieve the goal. So goal is to provide the best anatomical and the functional improvement, whatever is possible. And Distraction histogenesis has the ability of distracting and reconstruct with the limited tissue available in the deficient hand. And it was first described by Matthew in 1967 for the metacarpals and then for the phalanges. The primary goal is the improvement of the length with the enhancement of the mechanical function, prehension, grip, with the overall functional improvement and secondarily cosmesis as well. So what the distraction does, it not only increases the bone length, but it also enhances the neuromuscular and the soft tissue complex as such. These are the Schanz pins. This is the assembly. This is the second incision made. The fixation of the pins. Now preparing for the osteotomy or corticotomy in between. And this is the closing of the periosteum. And this is the final. So average degree of shortness in our patients was 20.4 mm and the length achieved was 15 to 25 mm. This is the case of the distal phalangeal amputation of the thumb. This is the osteotomy site made. This is the mounted of the assembly. This is the distraction in progress. And this is the fully consolidated bone with the removal of the distractor. And this is the final result with the increase in the length. And this is the fine grip as well as the improved pinch. And the patient with the loss of the distal phalanx and the middle phalanx of the index finger. This is the assembly mounted. This is the distraction in place. This is the complete distraction on the right side. And there is an increase of 30 mm of the length. And this is the consolidated bone. And this is the final result of the improved pinch as well as the length, as you can see, comparing the pre and post. This is another patient with the loss of the half of the middle phalanx and the distal phalanx of the ring finger. Again, the same thing. There is an increase of 22 mm of the length. This is the consolidated bone. And this is the final result. So, with the increase in the length, the depth as well as the width of the first web space is improved and the functional capacity of the hand is increased as well as with the aesthetic improvement. Advantage is that phalangeal lengthening can be performed on more than one finger simultaneously and the lengthening of the short stump of especially the index finger causes improvement in the pulp to pulp as well as the pulp pinch grips. We have very little experience. We have done only 12 cases. In our experience with the appropriate selection of patients, the technique provides safe, reliable, and predictable results. Not only is there correction of the osseous defects, but also gain in the soft tissue that is sensate with a good blood supply. Thank you.
Thank you. Are there any questions for Dr. Umar? Yes.
Excellent paper. Thank you, sir. So a couple of technical things that I want to ask is, what is the size of the Schanz pin that you use for the phalanges, for the metacarpals, number one. Number two is, can we get away with just using K-wires? And number three is, what is the maximum length of length that we can get back in your experience, lengthening these? What is the maximum?
Maximum length which we have gained is the 32 mm.
And how long did you keep these distractors, the assembly?
First of all, we keep the distractor what the length we want to achieve. Then for the consolidation, we again keep it for around maybe, our average was just 90 days was the average for the consolidation.
Yeah. Did you ever have to bone graft like we do in tibia?
We didn't put bone graft in any patient.
No patient.
No.
And why Schanz pins and not K-wires? Because the Jess assembly comes with K-wires, the ones that we get. So can we use K-wires instead of Schanz pins?
I have no experience with the K-wire. We have put the Schanz. I have no experience with the K-wires.
And I'm sorry, the last question is, do you have a different size of Schanz pins for the phalanges and the metacarpal?
No, same.
Same thing. Okay.
Yes, please.
For distal phalanx level amputation, would you distract middle phalanx or proximal phalanx?
It depends. where you have the good, where metaphysics is good, if there is normal, middle phalanx will be, I think, better. So actually what diffraction is doing, you are only increasing the length.
Yeah.
So that you have a proper grip and all that. So I think distal middle phalanx will do better.
Basically, practically, your cases what you use on where the proximal phalanx was lengthened. And if you spare the PIB, functional and cosmetic outcome would be more better, what I think.
Thank you.
Thank you very much. So we'll go with our next speaker, Dr. Suham. He will be presenting about evidence-based management of thumb-based osteoarthritis.
Thank you very much. Good morning, everyone. I have great pleasure in bringing to you the evidence-based guidelines for managing osteoarthritis of the base of the thumb. Now, I say here a UK perspective because that's where I work, but the evidence is international, so it's applicable everywhere. So a little bit about the process of producing the guidelines. The British Hand Society produces guidelines to treat and optimize common hand conditions like this. And it does so through its research committee, who in turn appoint a guideline development group to do the actual work. The group consists of a lead and various core stakeholders, usually surgeons and therapists, but we also consult general practitioners, commissioners who pay for the service, and not least of all, patients. So everyone involved in the management gets a say. Now, in this case, this is the group that I led. Without the work of these hardworking individuals, this guideline wouldn't have been possible. Now, the guidelines are produced by using a very strictly defined method that is written down in this BSSH Best Guidelines Process Manual. Now, essentially, it is done through systematic reviews. We did systematic reviews of level 1 studies investigating the treatment of thumb-based arthritis. And these reviews, the evidence from the reviews was then converted into guidelines using the SIGN 50 rules. So it's a very well-regulated and rigorous process which you have to follow to get accreditation. Now, the systematic review details are beyond the scope of a 5-minute talk. So really, just a very brief summary. So we looked at the entire evidence and screened out 47 papers, which we included. And these papers we looked at to answer 3 key questions. Are non-invasive treatment by way of education, exercise, and splints effective in treating thumb-based arthritis? Are steroid injections effective in thumb-based arthritis? And finally, are surgical treatments effective? So the headline answers are as follows. So non-invasive treatment does provide clinically useful improvements in pain and function, and there is high evidence for this. Non-invasive treatment includes all these multimodal components: exercise, education, task modification, etc. But importantly, we found that when the patients take ownership of the condition and may play an active role in improving their function, it works best. Steroid injections do improve pain and function. The evidence is that it does so for short lengths of time, up to 6 months, usually 3 months. Surgery does also improve pain and function when compared to the preoperative state. When surgery is performed, trapeziectomy is the most commonly performed operation. It is most commonly performed with, commonly compared with other operations, particularly LRTI. And from our review and many other reviews to date, we could not find superiority of any other procedure over trapeziectomy for improvement in pain and function. So all these results were then converted into guidelines as follows as clinical practice recommendations. We recommend that any patient coming with thumb-based arthritis should be offered conservative management, a multimodal therapy regime, and ultimately supported self-management package. If that is not sufficient, we offer splints. If that is not enough to control pain and function, then steroid injections can be considered. And finally, if the patient remains symptomatic, consider operations. And when we do consider surgery, trapeziectomy seems to be as good as any other operation. Now, there is a lot of detail in the actual document, which I can't bring here, as to how to practically implement these guidelines. And they include a number of tips and tricks, and they also include things like this, which is a patient flow algorithm following the patient's journey right from the beginning, presentation to the GP, to finally being treated surgically and discharged. It also has these links on the actual document to guide patients to the websites to be able to help them self-manage their condition. Now, the guidelines available at the BSSH website for everyone to download and follow and give their patients, or through the QR code. Thank you very much.
Thank you very much, Dr. Sahan. Any question for our presenter? I think it's pretty clear guidelines for everyone to follow. I have one question regarding the cortisone injection. How often we go with that till we say there's no effect when we should go for surgery? How?
So there is no evidence as to how many cortisone injections you can give, and it's the subject of a new study that we're undertaking now. But generally, the consensus of the group and experts was that if it works for around 6 months, you can repeat it. So if it's less than 6 months, it's probably best to move on to something else.
Okay, thank you.
Dr. Som, I've got another question for you. It's very nice work. Some of the treatments are established, like trapeziectomy, LRTI, and some of them are changing. That means the implant arthroplasty that was done 10 years ago is very different from the one now. How do you account for these changes in this process? Do you review this in 5 years, 10 years? How does it work?
Yes, so it's reviewed every 5 years. That's correct. And I think the new SCOOT study that has just come in comparing conservative versus trapeziectomy versus implant with the new model implants will give us, may give us a different answer.
Thank you.
Thank you, sir. Now I invite our next speaker, Dr. Syed Mohammad Noman Quadri. He will be speaking about functional outcome of trapezectomy and mini tightrope fixation in first CMC joint arthritis.
Good morning. I'm Dr. Syed Mohammad Noman Quadri. My topic is functional outcome of trapezectomy and mini tightrope fixation in first carpometacarpal joint arthritis. Coming on to the introduction, it's the most common degenerative disease of hand, mostly seen in women with 2:1 ratio. Anatomy, it's a biconcave convex saddle joint with minimum bony stability and maximum managed by ligaments, mainly anterior oblique ligament. Etiology in women, relaxin hormone causes excessive ligament laxity and repetitive loading leads to erosion and arthritis. EATN has classified into stage 1 to 4, where 3 is the maximum joint damage of a CMC. Stage 4 is involving other joints like scapulotrapezial joint. Few tests, axial grind test and traction shift test. Traction shift test has high sensitivity and specificity. Here we have various operative treatment modalities starting from extension osteotomy to arthroplasty and arthrodesis. But here we are discussing only trapezectomy with mini tightrope fixation. Aim of our study is to evaluate functional outcome. This is a retrospective observational study with sample size of 16 done at our institute. We have followed up on physical examination with follow-up radiographs at 3 months and 12 months and questionnaire method like Quick Dash and VAS to assess the patient satisfaction and their pain levels. This is the overview of the Quick Dash score and the pain score. This is the mini tightrope set, which contains corkscrew and the suture thread and oblong button and suture passing K-wire. Coming on to the surgical technique, where we expose the joint and using a corkscrew, we remove the trapezium. It can be in toto or piecemeal, followed by removal of any loose bodies. And now we have passed the suture passing K-wire from base of the first metacarpal to the second metacarpal. And this is the suture with the oblong button. It's passed from base to second. Finally fixed and the suspension is done. There's a few CM pictures. Half of our patients were in the age group of 45 to 54 years with female predominant and involving their dominant hand. and most of them were a housewife. On final follow-up, our results have shown a remarkable improvement in quick dash and VAS of 0 and Kaplan of 10 and palmar abduction of around 90 degrees. Few case reports. This is the 51-year-old female. She is a housewife. This is a pre-op X-ray with basal joint arthritis. On 3 months follow-up and 12 months follow-up, this is a post-op X-ray. These are the clinical pictures. Next is a 54-year-old female with a housewife and pre-op X-ray. This is a 3 months follow-up and 12-month follow-up. 2 weeks post-op clinical video. She has good range of movement. Third case is of a 55-year-old female with basal joint arthritis. We have seen at 3 months and 12 months. And 2 weeks post-op, she was able to do activities. Complications we have encountered, like Z deformity and subsidence in 3 patients. And our study was compared with various other studies and shown remarkable improvement as comparison with Gianfilippo and Yao et al. With good VAS score and Kaplan score. Limitations of our study includes like it was a single center and has small sample size. It was done for a short term, and we haven't assessed the grip and tension strength and did not compare with any other treatment modalities. I finally conclude saying that mini tightrope helped in early mobilization, which in turn lead to faster rehab and shorter recovery, overall improvement in quality of life. Thank you.
Thank you. Any questions for the speaker?
A nice presentation, excellent work. My question is, why is this better than just doing a trapeziectomy, right? I mean, we still get great results with trapeziectomy, and I differ with the subsidence being a complication. It may not be, I mean, it is not exactly a complication, having subsidence of the first metacarpal. And why is this better than just doing a trapeziectomy?
Because we are able to hold the first and second metacarpal in place and allowing the space between first and second, which allows good range of movement. With the lone trapeziectomy, there won't be a ligament, there won't be any stabilizing factor, and suspension helps in stabilizing.
Okay, thank you.
Yeah.
The next free paper we have is by Dr. Ajish Sankaran. He's going to talk about the syringe external fixation technique for complex hand fractures.
Thank you. Good morning, everyone. So, the technique that I'm going to present today is using a syringe barrel as an external fixator. So, common injuries in India nowadays from road traffic accidents, that's an open middle phalanx commuter fracture. And obviously, the options are not simple in any case. So, we'll see how, so this is the technique that we sort of tend to use for these sort of fractures. So, in external fixation of the hand, I guess the ones that we are most commonly familiar with would be the Suzuki, as we can see on the left, and the Jess, which is available in India. And apart from those, the other options are very limited. So in 2020, this study from the Curtis National Hand Center came up with the syringe external fixator idea of using the barrel of a 1 ml syringe, which is insulin or tuberculin syringe, as the external fixator. And this is a case that they had reported back then, and you could see how the pins are transfixing the barrel and onto the fracture as well. So they also described how this could be changed from a static mode to a dynamic mode. So by removing the most proximal pin, they are now able to free up the PIP, and the patient can be mobilized at the PIP level. So you are actually having an advantage of starting with a static fixator and then converting into a dynamic one. So a similar case, we had a closed middle phalanx-based pylon fracture that a preference for a simple dorsal fracture dislocation would be a Suzuki, but this is not one. This is a pylon fracture. We have a separate dorsal fragment as well. And we treated that with a syringe external fixator. And the point here is that the proximal phalanx pin, the distal one, is actually placed similar to Suzuki through the axis of rotation of the PIP. And that allows us to convert this into a dynamic mode later. So after we remove the most proximal pin, now the PIP can be mobilized. And that's a follow-up at 4 months. And the patient managed to get a pretty good result as well. And how is it done? So we use a standard insulin syringe, or the 1 ml insulin syringe, take off the peripherals, take only the barrel. And we use KYs of whatever size we feel appropriate for the fragment that is to be fixed. And that's just a short video of basically what we are planning on doing here. And the idea here is that the syringe express gives you the freedom to use any number of wires in the finger of any size. So of course, usually you would end up with 1 mm, 1.2, 1.5, but all of them would work, whichever you think would be the most appropriate for the fragment you're trying to fix. And that would get any angle as well. I'll try to illustrate that. So this was a closed middle phalanx fracture, and we decided to fix this because this was a press machine injury, and we wanted stability to mobilize and the hand to not get stiff. And the method, obviously, we use the syringe external fixator. And if you look at the most proximal couple of pins, we managed to put 2 pins pretty close together and also at an angle to each other. Now, to me, that is the advantage of the fixator that we're using. Because we're able to get 2 pins into that fragment, we need not span the PIP, and we can immediately start mobilizing the PIP as well. And an important aspect of the syringe external fixator would be that it is radiolucent, which means that you can get a proper lateral view without taking it off. Often when you place an external fixator in the finger, to get a proper lateral view, you might actually have to take the metal fixator off, get a view, and then take a decision whether you're going to remove the wires or not. So obviously it's inexpensive. It's billed at around rupees 10, 12 cents dollars, and it's easily available in every OR. And lightweight, when you look at the specifications, it usually comes to about 4 grams. And some cases, that's in open comminuted proximal phalanx fracture, that's an X-ray. And we treated that with the external fixator for about 5 weeks. And this was the case that I had shown earlier with a very comminuted middle phalanx fracture. So we used the external fixator along with the fragments. There were too many fragments to handle, so a couple of KYs were also placed. The X-ray looks quite horrible, but then we managed. There were no bone grafts or anything done. This was just one procedure, and that's the sort of function that we were able to get. There obviously is a restriction of movement, but I guess given the nature of injury, a fair sort of function. And then obviously we end up with these situations in multiple injured patients. Patients had multiple lower limb injuries as well. And here all the metacarpals, the proximal phalanges fractured. So now we have a choice. That's a substitute condition. So now you have a choice of trying to either fix everything or not fix anything at all. So that's what we went with 3 external fixators for the middle phalanx and the metacarpals. And those were removed at around 6 weeks, and we managed to get union in all of the fractures as well. So the syringe X-fix keeps it simple, it's versatile, it's cheap, it's light, and makes life easier, and having one more option in the armamentarium of the surgeon. Thanks a lot, and I would like to invite you to the Indo-US conference coming up in March in Kolkata as well. Thank you.
Thank you. Are there any questions for Dr. Sankara?
Hey, yes.
If you're treating a proximal phalanx fracture, do you not find if it's a basal fracture, there's no space to put the syringe in? Do you put it dorsally or?
You still try to go laterally, not exactly dorsal, because you would definitely end up transfixing the extensor apparatus when you try to do that. But that problem stays for every external fixation that you're trying to use. So I guess we'll have to work our way around that by keeping it towards the lateral side, but not exactly dorsal. Yeah. But for every external fixation, that problem is going to stay anyway, so of having to transfix the extensor expansion.
Okay, thank you.
Any trick to hold it reduce when you are passing the KY? Any simple trick, or because it's so much comminution, how you are able to pass that?
So if they're open, obviously that's far easier because they're already then fragments are under your control. But when they are not, the one difference with the JES is you will not be able to distract this after you have applied the fixator. So once you put the proximal pins in, we apply traction, try to hold them together, and then just drill straight through. And the one thing that one trick that maybe I would like to share is to first put the pin through the barrel and then apply traction before going through the bone as well, rather than trying to do all of that in one step. To break it into 2 steps, place it through the barrel, give traction, and then let it go through the bone as well.
But one more question for you. Sure. I've seen this technique applied where they have put cement in the syringe to sort of make it rigid. Do you think that is necessary, or do you think yours is a bit soft? Does it fracture the syringe or the interface between the pin and the syringe because of movement?
So we have never had any fractures or even pin loosening, because we usually tend to remove it at between 4 to 5 weeks. I guess if it went longer, we could really have trouble with that. The cement problem is again the problem with the lateral view and the proper x-rays. When you put a cement thing, it's difficult to get a lateral view. And the other problem would be you would not be able to convert that into a static one, because it's difficult to pull out that most proximal wire to convert it into a dynamic mode. So those issues remain with the cement one.
Thank you very much.
Thanks.
So our next presenter, Dr. Krishnan, he will be talking about survival and functional outcome in major upper extremity trauma with associated vascular injury.
Good morning, everyone. So I'll be talking about outcomes in major complex upper extremity trauma with associated vascular injuries. So when we talk of complex injuries of the upper limb, they can present in varying forms. It can be glaringly obvious, like in the left side picture, where there is a compound injury, there is fracture and injury to most structures. Or it could be a simple wound on the surface. This was a gunshot injury, which can cause shattering of the bones inside, along with vascular injuries. So in either cases, the management involves the standard steps. That is, the patient has to be stabilized systemically, resuscitated, and along with that, radical debridement, vascular repair, bone fixation or stabilization, repair or reconstruction of vital structures and their cover. The most important thing when it comes to vascular injuries is the time factor. All of these have to be done quickly and in a decisive manner. So this study, we aimed to look at the survival and outcome following management of complex upper extremity trauma, which were associated with vascular injury. So this was a retrospective study where the case file of patients who underwent treatment for compound upper extremity vascular injury were analyzed over a period of 10 years. So we had a total number of 317 patients, out of which 71 had primary amputation. The decision on whether to amputate primarily or not depends on whether the hand is structurally intact and also the ischemia time. And the final decision is quite often taken in the operation theatre after debridement and assessing the structures. And out of these, the limbs which were avascular were 41. The others had vascular injury associated in form of brachial artery or axillary injury, but the hands were vascular through collateral circulation. And in 60% of these patients, we had to use transient intravascular shunt. This is a very useful tool which helps in cases which present slightly late to us, so that we can delay we can reduce the ischemia time. So 34 of these patients had nerve injury. Nerve injury becomes an important factor when it comes to functional outcome. When there is no associated nerve injury and it's mainly bone, soft tissue and vascular injury, the outcomes are much better compared to when there is associated nerve injury. The most common flap that we used to cover was ALT free flap, which is 27. There were 2 cases where we had to do a flow-through flap. One patient underwent secondary amputation because of infection and blowout. There was 1 death due to an unrelated cardiac event. 5% patients had partial flap necrosis, which had to be managed with another pedicle flap. And when it comes to outcomes, 73% of these patients who were laborers required change of occupation as they could not use the hand as effectively as before. 20% had cold intolerance, and surprisingly only 3% agreed to undergo secondary surgeries, though most of them do require secondary. Some case example, this was a 32-year-old male who had crush injury along with fracture of the humerus, ulna and associated vascular injury. So the steps are radical debridement, and we repaired the brachial artery using a vein graft to the ulnar artery. So this was covered with latissimus dorsi serratus anterior chimeric flap. We used this flap as the defect was large and near circumferential and the nerve was intact. If we thought we required secondary surgery for nerve reconstruction, we might have preferred a fasciocutaneous flap. So this was used to resurface the defect, and the long-term outcome was fine with the preserved limb and movements. There was a gunshot injury to the right wrist and distal forearm where all the structures were injured. There was bone injury, and there was also a gap in the median nerve and FCR tendon, and also a soft tissue defect. So this was all-in-one reconstruction was done for this patient. So the vein graft was used for the ulnar artery, cable nerve graft was used for median nerve, and also an interposition tendon graft for FCR. Cancellous bone graft was used for distal radius, and along with this, a flow-through radial artery forearm flap was done to reconstruct the radial artery also. So this is the outcome in the long term with this. He had good grip strength, and the functional outcome is good. The flap is also well settled. The best reconstruction is most often all-in-one in the primary setting, but quite often we're not able to do that in cases where the contamination is more. So this was a soft tissue loss with brachial artery injury, reconstructed with ALT musculocutaneous flap and a brachial artery vein graft with good functional outcome. So to conclude, early radical wound debridement and early soft tissue cover with primary reconstruction of all the structures as far as possible gives good functional outcome. The determining factors are whether the patient is compliant with physiotherapy and regular follow-ups after surgery, and also whether there was nerve injury or not. Thank you.
Thank you very much, Dr. Krishnan. So any question for Dr. Krishnan? So I have a question. In case you are not able to cover the soft tissue defect with a flap immediately, for how long you will wait to do the second stage?
Even after the vascular repair?
Yes.
We normally wait for a maximum of 24 hours. Suppose the patient has come in the emergency in the night, we do the vascular repair, cover it with collagen, reassess in the morning, and most often in the next morning we go for a free flap cover.
Okay. Please.
Excellent paper, sir. The one case that you showed, there you took that, repaired that ulnar artery with a vein graft. And in that same case, you did a radial artery flow-through flap. In a case where both the arteries are injured, don't you do repair of both the arteries?
Yeah, we had put vein graft for the ulnar artery, and when we do a flow-through with radial forearm flap, we are repairing the radial artery also. So because the radial artery flow-through was distally attached, radial forearm flap was distally attached to the radial artery. So in effect, we are reconstructing both.
Okay, thank you.
Thank you, Dr. Krishnan.
Thank you.
Now I invite our next speaker, Dr. Deekshit, to talk on functional outcome of management of PIP joint injuries of the hand with Suzuki frame and interfragmentary screw fixation.
Good morning, everyone. This was our study on functional outcome of management of PIP joint injuries with Suzuki frame dynamic traction and interfragmentary screw fixation. PIP joint injuries are commonly encountered injuries of a hand, often neglected or undertreated. The mechanism of injury is axial impaction on extended fingers, which is most common, and they usually present with pain, stiffness, instability, premature degenerative arthritis, and with residual deformities. There are different modalities of treatment, ORF with interfragmentary screw fixation, extension block splinting, dynamic X-fix traction, hemiamate arthroplasty, and volar plate arthroplasty. The aim of our study was to assess the functional outcome with Suzuki frame dynamic traction and interfragmentary screw fixation. It was a prospective study done from Jan 2022 to April 2024. There were 38 patients with PIP joint injuries, out of which we did Suzuki frame in 12 and interfragmentary screw fixation in 12 and 16 other with hemiamate and extension block K-wiring. The inclusion criteria was more than 18 years, acute and subacute cases, and patients with vascular and nerve injuries, and the patient who needed simultaneously reconstructive soft tissue procedures were excluded. Out of 38 patients, 24 patients met inclusion and exclusion criteria, and Suzuki frame was done in the cases who presented within 6 weeks, where the fragment size was less than 2 mm and articular surface involvement was less than 20%, and interfragmentary screw fixation was done in the acute cases who presented less than 1 week, where the fragment size was more than 2 mm and articular surface was more than 20%. The clinical and radiological evaluation was done at 2 weeks, 6 weeks, 3 months, and 6 months. Parameters such as pain, range of motion, X-ray findings and complications, and the Quick-9 score was noted. Out of 24 patients, male predominance of 21, and all the patients were right and dominant individuals. Our study showed middle finger was most involved, followed by ring and index. The pain at the end of 3 months, the VAS score was 0 with ORF with interfragmentary screw fixation. But the end of 6 months, both Suzuki and ORF had 0 VAS score. Coming to the mean PIP arc, it showed a gradual improvement at the end of 6 months. And even the Quick-9 score, the lesser the score, the better the outcome. The mean score was 12 for the ORF and 6 for the 12 for the Suzuki and 6 for the ORF. This is the one case with volar base fracture with dorsal dislocation, where we had done the Suzuki frame. At the end of this is the 3 months X-ray, where it showed the complete union with almost 90 degrees of range of motion. And this is the one more case where the articular surface was more than 20% involvement. We had done ORF with mini fragment screw fixation. And this is at the end of 3 months, where the wounds had healed completely and almost he had a near normal range of motion. This is the one of the X-ray which showed over distraction in Suzuki frame dynamic traction. We had 2 cases as such, where we removed the K-wires and allowed it to dock back, and there was better results over time. And there was also DAP joint deformity in 2 cases who had undergone Suzuki frame, and there were no any wound complications. And in the Suzuki frame, our results was comparable with the other studies. Our study showed a mean PIP joint arc up to 86 in Suzuki frame, and in ORF, our study, again, it was comparable with the other studies. Our study showed a mean PIP arc up to 1 or 2 degrees. The dynamic external fixator helps to maintain the concentric reduction, and it also allows controlled range of motion, and also allows the early range of motion. It mainly works based on the ligamento-taxis. So I would conclude by saying a Suzuki frame technique for PIP joint is a simple, minimally invasive soft tissue sparing, allows early ROM, but it is technically challenging. Suzuki frame is preferred in acute and chronic cases when the fragment size is less than 2 mm and articular surface is less than 20%, whereas ORF, when the fragment size is more than 2 mm and articular surface involvement more than 20%. Thank you.
Thank you, Dikshit. Questions?
Up to how long you can prefer to give a Suzuki frame? What's the duration?
So almost all the cases were less than 3 weeks, but 2 cases which were more than 2 weeks. Since we attempted an open reduction, since the fragment was still mobile, we gave an attempt, but it still gave a good results for us. So we considered it up to 6 weeks.
6 weeks?
Usually all the phalangeal fractures heal by then, but since when we opened it, still the fragment was mobile, we tried on those 2 cases.
But you cannot, that will not heal, no? By closed means?
No, we tried an open reduction in those 2 cases.
Okay, you open it and then you fix it with a
yes.
Suzuki frame.
Yes.
Okay.
Thank you.
Dr. Mudgal?
Thank you. I must applaud you for your study. I think it's nice to see 6-month follow-up, but I have a comment and a question. So the first thing is I had noticed on the lateral view of your Suzuki frame as well as on the ORIFs that you had a dorsal V sign. And despite having a dorsal V sign, you showed pretty good outcomes. So my question to you is, do you attribute any significance to the dorsal V sign? And do you think you need to follow these patients longitudinally to see if your results break down with the passage of time?
We followed up till 6 months. Till then, this is the results, whatever we have.
Okay. If there are no more questions, then we'll take the next one.
Yes.
Okay. So the next one is by Dr. Das. He's going to talk about reconstructing a mangled wrist and a step-ladder approach for that.
Yeah, good morning, everybody. I would like to share my experience on treating a patient with a mangled wrist and a mangled hand. Mangled injuries are quite common in Indian scenario, and this term, the mangled or mutilating hand injuries, are often used on a spectrum of patients where multiple structures are affected due to the injury. And as it involves many hand structures, and the radial digits in the hand provide the key and the chuck pinch, and the ulnar side is responsible for the grasp. There are many associated injuries also, which we should take care before treating these hand injury, the mangled injuries. The functional outcomes, however, depends both on magnitude of the injury and the multiple secondary reconstructive procedures. It should be a step approach. The assessment should be preferably done by a senior member of the team. We should first decide whether to replant or revascularize any injury which is there. So that takes the priority, and if there are no such scope or possibility, we go for the radical debridement, that is the sharp surgical debridement. Negative pressure therapy, skeletal stabilizations, then follows the coverage of the wound, and finally delayed restorations like bone substitution, transfers, and finally, if the results are not up to the patient's expectations, sometimes difficult decisions like delayed amputations. Occupational and hand therapies always are important. So this is my step approach should be preferred because it involves multiple structures, and treating everything at one go becomes difficult. There is always injury in evolution in this type of traumas. There are sometimes gross contaminations. The skeletal injury not only involve bone but also joints which have tender structures like cartilages. And most are large defects, and there are always issues with consenting and finances, especially in injury in industrial setup. So these are Entin's strength, position, length, stability, mobility, and sensibility. These are the basic requirements for hand function. So a minimum good hand function needs 3-digit hand with a good mobile thumb and functional PIP joint. So the timing of presentation and the wound contamination are the determinants. Right-handed male, 18 years of age, working in industry with roller machine injury, presented to me in July. He presented 6 days after the injuries. There were right wrist and hand wound with contamination. There were loss of radial extensors, radiocarpal instability, thumb instability, and loss of first metacarpal. We did a skeletal gist frame fixation to maintain the height of the wrist joint as well as the metacarpophalangeal joint. And then this was the defect in the initial X-ray and a K-wire along with it to stabilize the thumb temporarily. Then we did a re-loop debridement and planned for a definitive wound cover. We wanted to have a stock of the situation before deciding on the final procedures. I did a pedicle extended groin flap to initiate the equilibrium in wound healing. This is the result after the groin flap with still the external frame and the K-wire on. Then we took a decision to see what effect it has when we remove the external frame. And when we removed it, there was still, the wrist was going into an unstable area, and it was severe radial deviation. We planned for a skeletal reconstruction by osteocutaneous free fibula with 2 segments, one osteotomy for 4.5 and 2.5 centimeter each, fixation with a low compression, low profile DCP, and K wires for thumb flexion. This is the intraoperative views. Then this is the early results after the flap reconstruction, and this is the result after 3 months of the free fibula, and this is the result. We can see that there is fairly good thumb to index finger pinch. We reviewed our results. The thumb is short but stable. It shows less than normal opposition, no key pinch, and the patient changed his profession to a headphone maker. And these are the very recent photographs. A final plan is to do a distraction of the thumb of our bone in the thumb, which we have done through the free fibula. Still something is missing, and this is the video which shows the scene of the accident sent to me by the patient, and this is before the free fibula, before the free osteocutaneous fibula with the flap coverage, and this is after the flap coverage of the fibula. Thank you.
Any questions for Dr. Das?
I'm Dr. Babu, excellent presentation. My just question is why you have not done the first instances of the free flap? Instead of avoiding the groin, you would have done.
Yes, sir. In this case, I think the contamination delayed presentation 6 days. There was a chance where we could have done the groin flap together along with the extra. That's what you are asking, no?
Just one flap, just one free flap alone would have solved it. No?
Yeah, where I do my practice, and we get a lot of patients who present early, most of them. It's a general consensus that if the patient presents late, like say at 7 days, we avoid doing a free flap because of the wound contamination, because of the chances of thrombosis due to infection. We still follow the old school. We wait for 2 weeks, whack the wound, settle it down, and then go for a free flap.
Thank you.
So thank you very much.
Thank you.
We'll go to our last presenter of the session, Dr. Vedanti Rajesh. She will be presenting about Zone 1 flexor tendon repair and rehabilitation, a single center experience.
Good morning, respected teachers, seniors and colleagues. I'm Dr. Vedanti Patil, and I'll be presenting a case series on Zone 1 flexor tendon repair and rehabilitation, a single center experience. So we all know the anatomy and the biomechanics of flexor zone 1, so I'm not going to go in details of that right now. The consequences of an unrepaired FDP is loss of DIP flexion and loss of fine functions like fine pinch, power gripping of large diameter objects, and span pinch. We all know the Moyman and Elliott subdivision of flexor zone 1, which we have used for classifying our laceration cases, and the avulsion cases were classified as per the Leddy and Parker classification. This was a retrospective observational case series from 2010 to 2023, including 9 patients aged from 8 years to 54 years, including all the laceration and avulsion cases of FDP in the flexor zone 1. We excluded the palmar plate ligament injuries and phalanx fractures, obviously other than the ones which were involved in the type 3 and 4 avulsion injury. and concomitant replantation and revascularization. Our assessment was done using the total active motion evaluation system. So this is the injury and site-specific repair techniques. In laceration zone 1A, we use the tendon to bone repair using the pull-out suture with button-on nail. In zone 1B and 1C, we used a tendon end-to-end repair using the forced anchor with epitendinous suture technique. In avulsion type 1, we used a single-stage PL graft with Pulvertoff technique at the proximal end and a pull-out suture with button-on nail at the distal end. In type 2, we used a tendon to bone repair. In type 3, we fixed the distal phalanx fracture with the screw. And in type 4, we used the tendon to bone repair or single stage PL graft with distal phalanx fracture fixation with screw. In an old neglected trauma which necessitated the excision of the vitalized tendon segment, we had to use the two-stage tendon repair technique. These are some of our cases. This is a zone 1B laceration. Here we used a tendon end-to-end repair. Here the A5 pulley was preserved. Here we did a hemi FDP end-to-end repair. So here basically the FDP was seen to be thick, hence we split it longitudinally, and hemi FDP was repaired end-to-end with a 4-strand and epitendinous sutures technique. Here the A5 pulley was preserved and the remaining FDP was sacrificed. This is in the type 2 avulsion injury. We did a tendon to bone repair using the button technique. Here the A5 pulley was dissected and the fibrous tissue was excised. The A5 pulley had to be sacrificed. This is a single stage PL grafting done in type 1 avulsion. Here the C3 and the A4 pulleys we had to reconstruct. Here this is type 4 avulsion. We did the fixation of distal phalanx fracture using screw 1.7 mm screw. And the FDP was sutured to the base of the distal phalanx using the around the bone suture with knot on the nail using the button technique. This is an old neglected zone 1A laceration. Here we did a 2-stage tendon repair with silicone rod in the first stage, followed by PL graft in the second stage. So our rehabilitation protocol is by the early active mobilization. So as you can see on table, we give a splint with wrist in neutral, MCP in 90 degrees and IP joint straight. In first week, the dressing is removed distal to the MCP joints and flexion and extension active motion is started. Second week, the fingers are extended furthermore to 45 degrees at MCP joints. Third week, the fingers are extended completely. Fourth week, we remove the splint. And in fifth week, we start the blocking exercises. Our assessment criteria, as I mentioned, was a TAM protocol based on the normative data that has got published in the IGPS journal. And a TAM person had to be calculated based on the contralateral finger. So these are our study findings. So we had 6 patients of laceration, zone 1A having 2 patients, zone 1B 3 patients, and zone 1C had 1 patient, avulsion had 3 patients. And in time since injury, immediately attending patients were 5, and the late follow-up were 15 days 1 patient, and 1 month had 2 patients. There were no complications in our study. So as you can see, 8 out of our 9 patients, that is 89% of our patients had excellent and good outcome. The 1 patient who had a fair outcome was the one who had a concomitant crush amputation of his middle and ring fingers, which perhaps affected his final outcome in his little finger. So as comparison with the other similar studies, what we noticed that all these studies had used a different protocol than ours. We had used the early active mobilization. And in few studies, they have maintained the rule of whether to reconstruct the pulley or to release the pulley. So to conclude, the suturing technique that we would suggest is that for in zone 1A, we use the tendon to bone pull-out suture with button-on nail technique. In 1B and 1C, we use a 4-strand with the epitendinous suturing. If there is a significant tendon retraction or segmental tendon loss, then you go for single-stage PL tendon grafting. In a neglected old trauma, we would use the 2-stage PL grafting. And regarding the venting of pulleys, if there is an obvious risk of reduced post-op excursion of tendon, then we go for the venting of pulleys. And an early active mobilization protocol will always be helpful. These are my references. Thank you.
Thank you very much, Dr. Vedanti. So any question for our speaker? Please.
So I'm Dr. Karan from Surat.
Good morning,
Excellent presentation, ma'am.
Thank you, sir.
So for the zone 1 FDP, you are saying that you had split the FDP longitudinally.
Yes.
And how do you manage to get a 4-strand repair in a split FDP? That is what, because I find it difficult. I've many times settled for just a 2-strand repair, that too with a full FDP.
So in that case, the FDP it was found to be thickened, and hence we had to split it longitudinally.
Okay. And so you are able to start with like immediate active assisted mobilization.
So it's as I had showed in the slides, we start with the active mobilization. We ask the patients to start exercising. You need compliance of the patient in this kind of a protocol, basically.
Okay.
Yes.
Thank you.
Any further question? So, thank you, Dr. Vedanti.
Thank you so much.
Thank you. So with this, we close our sessions. Thank you very much.